I've had the privilege to be involved in several ADQI meetings over the years, and I was also honoured to be chosen to present the results of the latest ADQI, still the latest ADQI, I think, for another 24 hours or so, which focused on cardiovascular surgery-associated acute kidney injury. And we met in a beautiful part of the world, just across the Adriatic from here in Brijuni in Croatia, and we spent 2 or 3 days talking about the acute kidney injury that is caused by and follows cardiac and vascular surgery. And I'm going to present the results of that meeting here. So I don't have any disclosures relevant to ADQI. You can read about our work in the Journal of the American Heart Association. It's just been published. The lead authors, Mitra Nadim and Louis Forney, sadly are not here, but did a superb job of marshalling us in the form of 4 groups to think about various aspects of this disease process. In all, there are about 25 to 30 delegates attended, and we argued friendly and robustly for, as I said, 2 or 3 days to try and reach some consensus comments about the pathophysiology and diagnosis, prevention, and management of this disease. And then we concluded by making some recommendations for the research agenda, and I will talk through those groups as objectives for the next 15 or 20 minutes or so. So pathophysiology, diagnosis and risk assessment, prevention, and then finally management with some recommendations about what, if like me, you spend about 40% of your time looking after these patients, what does the evidence suggest that you may and may not want to do in order to maximize outcome? So let's start with pathophysiology. That was a fabulous talk just now about renal functional reserve, and really highlights the importance of dynamic assessment of organ function, which isn't something we've traditionally done much of in the kidney. And I think it highlights this gap between observable morbidity and pathophysiology. This is a reasonably old cartoon now that highlights the spectrum of disease from normal function all the way along to kidney failure and death. And what we now realize is there is the subclinical category of disease, which the tests and the tools are now just becoming sensitive enough to detect. So our group, and I was in the pathophysiology group, was thinking about this sort of spectrum of disease in the context of an evolving pattern of injury and repair, from vasomotor nephropathy, as the GFR initially is maintained, through initiation of disease and extension, where the GFR is really significantly impaired, and then thinking through maintenance phases and repair phases as we redifferentiate and repolarize our tubular cells. And the group decided and came to the conclusion that there are really 4 areas of pathophysiological significance. Hemodynamic perturbations, and those are the things that people like me spend a lot of our time thinking and worrying about. Inflammation and immunity, and I'm going to show you some slides from John's group that will hopefully illustrate the way we were encouraging us and our readers to think about in the context of heart surgery. Iron metabolism and free hemoglobin, its role in pathophysiology is increasingly important. There are pharma companies developing medicines to address the role of free hemoglobin, device companies developing products to address the role of iron in CPB-associated AKI. So we thought that was important. And then other mechanisms such as oxygen-free radical development, atheroembolic disease, particularly in the context of intra-aortic balloon counterpulsation, the place of venous congestion, and I'll make a few comments about that in a minute, and then the role of danger and pathogen-associated molecular patterns in inflammation triggering and extension. So here's a cartoon from John's group that summarizes the way you might think conceptually how the kidney is damaged from both local mechanisms but also from distant disease. The kidney is susceptible to delivery of toxins from 2 places, from the circulation and from the filtered molecules. These set up inflammatory signaling in the parenchyma, leading to further signaling that leads damaged cells, if you will, the leukocytes, to attack both the endothelium and the parenchymal disease. And our group was trying to think about and capture a way to depict that graphically, which I'll show you in a minute. From a hemodynamic perspective, it's important to recognize variations in renal blood flow at both the global organ and the corticomedullary interface, recognizing the imbalance of oxygen supply and demand. We talked a little bit about pulsatile and non-pulsatile bypass. Unfortunately, it's largely an academic discussion because almost nobody pulses if you do in the cardiac surgery setting. And the studies have not really definitively been able to demonstrate that one should. Something I think is underappreciated is the role of deep hypothermic circulatory arrest, because nowadays we use selective antegrade cerebral perfusion where the brain is not arrested but the rest of the body is. We forget how important that can be for initiation and or prevention of renal disease, particularly in the context of temperature and temperature management. Now, venous congestion is increasingly appreciated as important in heart failure syndromes, and so it is also in heart surgery. Depending on the type of surgery you do, the pressure in the IVC can be really quite high sometimes, and that can lead to a back pressure on the kidney itself. Whether or not that manifests as back pressure directly on the subarteriolar perfusion within the kidney, or it acts more as an overall pressure load on the kidney itself, is unknown. But we know in other organs, for example the brain, that when the pressure inside a semi-rigid container, when the pressure volume characteristics change, and you could argue that the renal pelvis occupies that same capacitance role, that might also affect intrarenal hemodynamics. The answer to how venous congestion is important is we don't know. But the fact that it is important is something that I think is now beyond dispute. We spent quite a lot of time arguing about the role of remote ischemic preconditioning, in particular because we had a couple of anesthesiologists in our group, whether or not propofol interferes with it or not. That is unclear, and interestingly, that field cannot progress until that question is answered, and so we think that that's an important issue for future research. This is a cartoon from a review paper actually talking about septic AKI, but it explains the concept of how damage and pathogen-associated molecular patterns are delivered to the proximal tubule so well that I like to use it in talks in heart surgery. And it illustrates the fact that the inflammatory process has to be initiated somehow. There's then implementation and extension, usually in the form of adaptive immunity, as the proximal tubular cells signal to their downstream colleagues that there is a dangerous environment, if you will, and to respond accordingly. And of course they do so, liberating and activating white cells in the parenchyma, which themselves cause sluggish peritubular flow, which manifests again further as reduced dysfunction. This is a pretty magnified example of what's going on inside a proximal tubular cell. You can see that as the S1 cells signal to their downstream components, the cell starts to vacuolize and has effects both on the mitochondria and also on the cell cycle. And the story of the cell cycle arrest biomarkers is not one to tell today, but it's increasingly realized as important both for diagnostic and now therapeutic reasons. So we summarized all this in a figure in the JAHA paper, which highlights the role at different levels: the macrovascular level, where hemodynamic management is important; the microvascular level, where other mechanical factors like emboli and arterial obstruction and venous congestion are important, down to the cellular level and the subcellular level, where things like oxidative stress, inflammation, and immunity are important. So that was group one. Group two were tasked with assessing and addressing risk assessment in the context of diagnosis. And so you're all familiar with the Rifle criteria. I won't belabor those. They became the Akin criteria, and I won't belabor those either, because they became the KDIGO criteria. And as you know, we're probably going to have another go at this next year. That's very exciting. This group, instead of focusing on diagnosis, which is probably not that controversial now, instead focused on risk assessment. And they did some good work describing the various clinically available tools and concluded that although they're useful from a population perspective, they still don't calibrate that well at the individual patient level, especially at the time when you're trying to make a decision in the preoperative period. They concluded, and I would agree with this, that pre-existing CKD dominates risk assessment and therefore management. And they also advised that we need to start thinking about using the available biomarkers, although it is still unclear how and when. I still think something that's really important that's come out of the various ADQI groups in the last few years is this concept of the transition from acute kidney injury through to ESRD via acute kidney disease before 90 days, chronic kidney disease after 90 days. And I think that's a useful contribution to the diagnosis and risk assessment. The graphic that this group came up with describes the transition of a patient through the preoperative no AKI period, where we focus on things like age and CKD, gender, albuminuria, the presence of concomitant disease, particularly concomitant vascular disease, through the period of intraoperative injury, where we focus on pump time. The management of cardiopulmonary bypass is something that is not well understood. We don't know what the right blood pressure is, for example. We don't know what the right thing to put in the prime is. That is an area that is ripe for investigation. Perhaps this is a time when stress biomarkers might start to indicate, as we just heard, that the patient is likely to develop detectable clinical disease, or if not detectable clinical disease, then this subclinical condition, so-called biomarker positive creatinine and urine output negative disease, and I'll make a comment about that in a minute. And then through to the situation post-operatively where the patient manifests their acute kidney injury and it's time to start thinking about implementing the KDIGO bundle. So a word about biomarkers and differentiation between intrinsic pre-renal disease and subclinical AKI. This graphic has grown out of a couple of ADQIs where it starts to illustrate the concept of detectable disease with functional loss as well, which we would call intrinsic AKI. Detectable damage but without loss of function, and this is where biomarkers manifest cellular stress or injury, so-called subclinical AKI. And then pre-renal azotemia, classically described as a loss of function but without detectable biomarker change. So that was Group 2, risk assessment. Group 3 functioned on prevention, and this group did a yeoman's work dissecting and trying to digest the literature about what has been studied in the context of prevention and when have those interventions been considered. And they considered perioperative, which includes treatments that can be given at any time, preoperative, intra, and postoperative. And they produced a really, really cool table, which I think is cool anyway. And so I'll go down it. This is the periop interventions. They grouped them out by whether they were relevant for cardiac and or vascular surgery. They either made a recommendation to use or to not use that particular intervention, and they measured the confidence with which they could make that recommendation in terms of grade analysis. And the two things which they were absolutely clear of, which I'm delighted as a fluids guy, is to use balanced crystalloid and not saline, and to avoid wide swings in serum glucose measurement. Dexmedetomidine is interesting. For those of you that aren't familiar with it, it's a short-acting alpha-2 agonist. It's a little bit like short-acting clonidine. There are some data suggesting it's beneficial from a renal perspective. Why it should be, we have no idea. But there are some positive trials, and that's another area for study. Josh Billings' work showed us that statins don't work. We know that N-acetylcysteine doesn't work. The Australians taught us that sodium bicarb doesn't work. There have been 2 or 3 large studies of levosimendan now suggesting that doesn't work. And the place, as I said earlier, of albumin and other additions to the pump prime is still uncertain. Preoperative preventative factors. Stopping ACEs and ARBs. Those of you that don't do that, please do. It makes my job a lot easier. Correcting hypoalbuminemia in patients having surgery we know is probably a good thing to do. Delaying surgery before contrast. When I used to work in the States, that was impossible. It never happened. Now I work in Canada, that's possible again, so that's good to know. And intra-aortic balloon pump placement is a controversial thing to do if the ejection fraction is not depressed. Intraoperatively, this is for people like me to pay attention to. Volatile anesthesia agents are probably renoprotective. Almost nobody gets anesthetized for heart surgery without one, though, so what its relevance is unclear. A vascular-specific recommendation was cold renal perfusion for AAA surgery, and then avoiding things that we know are bad for you: hyperthermia, pulsed hemodilution, and blood transfusion. Unfortunately, we know that both anemia and blood transfusion cause AKI. What we don't know is when to initiate blood transfusion. And as you know, there is controversy about whether or not there is or isn't a storage lesion in the context of transfused red blood cells. Postoperatively, the KDIGO bundle, 1B recommendation for cardiac surgical patients. Interestingly, and not a lot of people know this, the way you ventilate someone can have a profound influence on someone's risk for acute kidney injury. And again, recommendations not to use loop diuretics just for the prevention of AKI. That's not the same for removing fluid overload, where I think there's a strong indication. And then levosimendan and dopamine, and then the results of the clinical trials which have looked at this and been unsuccessful, such as alpha-MSH. Management. The management group focused on organizing the way they thought into whether or not the acute kidney injury was manifesting cardiorespiratory compromise or renal compromise, and I'll try and get into that in a minute. They did make some general recommendations about overall hemodynamic management, maximizing left and right ventricular function in terms of inotropy, maintaining mean arterial pressure in order to guarantee a respectable perfusion pressure, achieving and or maintaining sinus rhythm, and as a clinician I can tell you that's particularly important to do. Optimizing preload, this is Goldilocks on here, so this is a reminder, not too little, not too much in terms of preload. Minimizing elevations in pulmonary vascular resistance, because that's the prime determinant in the short term of right ventricular function. And I've just put up there to use vasopressin and inhaled nitric oxide. There are no vasopressin receptors in the pulmonary arterial tree, which is why it's a good vasopressor to use in the context of right heart dysfunction. And then, as I just said, low tidal volume ventilation. Management according to the extent of cardiorespiratory compromise. So the management group made a really interesting distinction between a patient who is expressing varying degrees of cardiorespiratory dysfunction, and these are the management strategies from the perspective of kidney function. And so they make the point of there's either no cardiorespiratory dysfunction, existing baseline acute or cardiorespiratory support, in other words, if someone is on full-blown ECMO. And they put this graphic into with increasingly intense monitoring techniques depending on the extent to which someone's cardiopulmonary condition is compromised. And then in terms of the extent of renal compromise, they talk about simple AKI with no complications, progressive, requiring renal support therapy, and then sustained acute kidney disease, if you will. And these are essentially variations on the KDIGO management bundle with different emphasis on different aspects according to whether the patient is primarily struggling from a cardiorespiratory perspective or from a renal perspective. They were pretty specific when it comes to managing fluids in patients with AKI, and this is a busy graphic, but it's in the paper. But what this does is it walks you through the top of the tree where you're faced with a critically ill patient who has already been resuscitated, and you have a dilemma about should I give more or should I give less fluid. And it asks you as you go down through this algorithm, is there evidence, clinical evidence of inadequate tissue perfusion? Is there evidence of clinical fluid overload? Is there an acute indication for RRT? If so, go ahead and dialyze. If not, it asks you about what's the patient's risk of developing fluid overload, and I think provides a useful approach to what is a difficult clinical situation. Someone who's already been fluid loaded but is continuing to be to misbehave from a hemodynamic perspective. And lastly, I said I'd talk about the research agenda. There's a nice little table at the end of this paper which talks about the various different categories and goals that our groups addressed and what's important in the research future for each of those groups. And I'll summarize it by saying everybody thought the development and validation of real-time monitoring would be important. How and when to use which biomarkers, we still don't know that. And then clinical trials to confirm or deny the efficacy of some promising new agents which have been shown to be positive in small phase 2 trials now need to be translated across to larger phase 3 trials. So with that, Mr. Chairman, I thank you for your attention.